If you're a cranial osteopath or you use CST techniques to work with babies, then you're going to see a lot of babies present with problems around the mouth and the latch. What I'm going to do in this video is answer a question from one of our students about this kind of case, and I'll just read that out to you now. The baby is 11 months old, is feeding well with good digestion, but the baby has had a lip tie release, and before that they were having trouble latching. They are reaching all their milestones in terms of growth, that kind of thing. But the holistic dentist is concerned about a high palate. So we get this kind of doming. So rather than being in this kind of position or too wide, which is very unusual, it's actually kind of peaking up here, high palate. And so the dentist is concerned about that. And so the mum has booked the baby in to see this practitioner. And the mum said that the baby's head looks elongated and too thin for his body. The practitioner is thinking the baby needs cranial work. Probably true. And the mum has also told me that the baby doesn't like sleeping on their back and immediately flips over when placed in that position. Any feedback would be greatly appreciated. Okay, so it's a good case to talk about, because when we talk about the face and we talk about the latch and we talk about the palate and all of these kind of areas, yes, there's a tendency to go, okay, well, obviously this thing is important here, but we mustn't forget what also is going on all the way down through the rest of the body and what's happening from the cranium coming back that is influencing the face. Because in many respects, what happens is that the face expresses from the forces that are put on it from the rest of the cranium and the rest of the body. And particularly if you think about a really obvious case with a mandible, when you have an underbite, kind of pops back like that, and you see this in a baby or an older child, well, that is a result of all the forces throughout the whole body, particularly through here, what's going on through the cervical region, cervical fascia, all the way down to the pericardium around the heart. And so there's this pull through here that contributes towards this kind of regression of the mandible. And so obviously, there's an adult skull, but you know, if we're thinking, whoops, the whole thing's going to fall apart on me, can I get it off? It's magnetized, so it's a little bit difficult. So we're thinking about that moving backwards, then yes, certainly, of course, the TMJ is important, but why is the TMJ in that position? We need to think about those forces. And I use that example because it's a really clear example of something that you see, wow, what's going on there? And, you know, just having dental work through this region, orthodontic work, without working through the rest of the body is not addressing it as well as we could. Okay, so to come back to this baby here, let's talk now about this baby. They've had the lip tie, so that's, you know, a tongue tie, and there may be influence through there that's been dealt with, or hopefully dealt with, because that's another video all in itself about whether you release by scissors, by lasers, whether it's fully released, whether they do the exercises, not, etc., etc. But we'll put that to one side and we'll talk about this baby that's coming in. What is this practitioner going to do? Well, the first thing is at 11 months, look, you know, that is trickier than 11 weeks in terms of treating, not so much because, you know, baby won't respond as well because they're older, not so much that, but because baby's going to be moving around a lot. So you're going to need to use a lot of transitions, putting babies in different positions, going to need to entertain baby. You've got to think about, if you're working on the cranium, work on there after working on the rest of the body. You go steam straight in on that on an 11-month-old, and they're going to be like, you know, get out of my face. And literally sometimes it's get out of their face. So when you're working on the cranium, working on the back of the cranium all the way up is going to be probably more significant in this case than actually working on the face and working in the mouth. If you work with babies and you try and put anything in front of them like this, you know, A, they're going to bite it, or B, they're going to push it out of the way, because, you know, you're in between me and the world. You're in between me and my mum. You're in between me and the toys. And so anything in this field of vision, working with a baby that's slightly older, actually we're younger as well, can spook them a bit, but certainly older at this age group, is not going to go down well. At 11 months, you're not going to be able to work in their mouth. They're going to have your fingers off. You might be able to work in them once. That'll be it. And then you'll be like one digit down and, okay, maybe I don't do that. And even working up through this whole area here, this will be a lovely area to work on. It just is not particularly practical in an 11-month-old. You know, you're going to look to them being quite a bit older in terms of that respect, into working through there. So one thing that you can use is a mile munchie, as these little devices, and I'll put a comment in the comments somewhere to tell you about mile munchies. You can look them up. They are maybe devices in different places in the world you can buy, but certainly in Australia, you can get them and get them very cheaply as well, which are $100. So they're a really good one for getting them in, and they can be on a stalk. So even an 11-month-old, they can go in and the baby can chew, and it can be quite safe. And that can help start working all of this mouth, working all of the proprioception, because the proprioception in this area is hugely important for the development. And if we're going to talk about this palate, and the palate has come down like this, then as well as the forces on that, we're going to mention those in a minute, you want to be able to get the tongue moving properly. And to do that, to help with that and the shape and the teeth, the proprioception, getting that myomunchi in can often be beneficial, because it's often been said, well, often, it's been said, perhaps not often, but it's been said that the best orthodontic advice, the best orthodontic device as well as advice in the world is to use the tongue. The best device for improving what's going on in the mouth is a proper position of the tongue and proper action of the tongue, because that's in there 24/7 and working. Whereas any other orthodontic advice, yes, you can put braces and things like that, and yes, they can be 24/7, but they're not as powerful as the tongue. And certainly, although we are starting to see orthodontic work coming in earlier with some of these devices, the myobrace and things like that, certainly you can get in a lot earlier with the tongue and a lot more powerful and be a lot more organic or holistic. But part of getting that all working is also looking at the forces from below and above. And let's deal with forces from below to start with. We've already mentioned in this case that the baby, I'll just flick back to there, doesn't like sleeping on his back and immediately flips over when placed in that position. So that's kind of unusual. To not be able to be on his back and to flip immediately would indicate that the baby is uncomfortable in that position. And so if we think about, that back like that, and let's say this is their head, so they're facing up and they're in that position, then, what are they doing to flip? Well, immediately my thought thinks of that they're maybe trying to get this little bit of extension going and flip onto their front. So there's something structurally going on there that we need to address. And what you can sometimes find, head and tailbone of an end, the sacrum, cranium, is that sometimes you get a little bit of extension as opposed to that flexion. If there's something going on with the dura, they get this tension through the whole dura, and the spinal column gets this compression. You can get, if you like, cord compression, not in a medical term where they say, cord compression, but we're talking now of this contraction through the meninges and dura that wants to bring the head and the tailbone closer together. And I've seen this also in adults, where adults are actually, they're tiptoe walkers. You get this in kids, but I remember an adult case, she was in her 30s when I saw her, was on tiptoes all the time, despite having operations to release through the legs and all the rest of it, would still be on tiptoes and had to wear high heels. She literally could not get her feet down. And what we worked on was actually on the dura and that cord compression, because what's happening is when that contracts, it was contracting up through the sciatic nerve down to the rest of the leg and causing that contraction up through the back of that whole chain, that posterior chain. So in this case, what we may be seeing is a similar contraction, although maybe not to the same extent. And so baby is like contracting like that. And if you ever put yourself in an extended position, it's very uncomfortable. So baby flips onto their front. Now we haven't seen this baby. Practitioner hasn't seen the baby yet. So we're just speculating. We're postulating different ideas. And the reason I do that, even if it's not the case in this baby, it gives you guys ideas about, okay, I wonder if that's going on here. I wonder if that's going on there. And so we may be seeing some kind of contraction through there. What are the possibilities? It may be that it's just very uncomfortable through the sacrum. There may be compression through the sacrum. There may be rotation through the L5, something like that, where it's uncomfortable on their back, or even through any of the vertebrae through there. Maybe uncomfortable through the thoracic region. And particularly that's an area that is going to, if it's sore, baby's going to want to turn onto their front and avoid that. Now that may then tie us in with all sorts of things in terms of ribs. It may be to do with the birth process and birth trauma, maybe first breath. There's a whole bunch of stuff that we could think about that I'm just putting out there so that we can start to think about that when we get these babies, and this practitioner can look into that when she first sees this baby. So a whole bunch of stuff that may be structural going on from the neck all the way down with me causing this baby to flip. And so the first thing we want to do is get in and do a good examination, up through the hips, up through the pelvis, up through the back, up through the arms, get them to lift their arms up and see if they're capable of doing that. If you do that now, you know me, I'm in my 50s, I do that, I cheat and I move back a bit. But if I try and do this against the wall, you'll see that I won't be able to put my arms up against the wall. Why? Because as those scapulars come up, as we get into that full flexion, then what happens is that I'm required to extend through the thoracic region. And I don't have that extension. I'm getting a bit old and a bit kind of croaky and a bit full of rust. And I haven't been doing enough exercise. And so you'll find that extension is preventing me. So what you can do is lie that baby down now on their back, which is going to be tricky. But the first thing you'll do is get in there and then quickly move both their arms up into that flexion and see if what happens. You know, do they immediately avoid it? Because if they are really restricted in that area, as soon as you put some kind of movement up like this, they're going to resist. And you're like, okay. Then you'd sit them up on your knee and you do the one arm and then the other arm. And then you sit them on mum's knee and you do that again to see what's going on with the thoracics. Now, of course, what happens is that sitting up, baby can extend. You know, they can actually extend and use their lumbars and bend back to avoid the extension in the thoracics. And so, but if you're watching for that, you can see what they do. So even if they do that, you can spot that and go, oh, hang on, definitely the thoracics is a key area here. Now, what happens is when you allow them to do that sitting, they'll perhaps show you more because they've got that little bit of a out. They can move away from it, but you're watching to see that, but they aren't in that really extreme uncomfortable position like they might be on their back. So this is when we're working with adults or babies, but particularly babies because they won't put up with pain. They won't put up with you doing things that they don't like, whereas an adult will lie there and allow you to do that to a certain extent. If you can think about these different positions. So if you can't examine baby in a particular way, like on their back, then you move them and you adapt and you really change the way that you do that. So you've got to really work these different patterns and these transitions and think on your feet. Okay, I can't examine like that, but I can like that. And when I see that, all right, okay, yeah, they're doing that. They're doing something different. You might move the knees, move the hips, use different ways of finding different information out in the baby. Let's say you've got a toddler comes in, they're 2 years old. They won't even let you touch you, put you on the bench. You sit them on mum's knee, they've got maybe a foot problem, a knee problem. Then you can just play a little game where you come up and just wobble their knee a little bit. Sometimes you need to eye contact with them and be a game. And sometimes you can just sneak up and they won't even know because they're distracted because they're sitting there with their attention on the bench with some toys. Now with a little baby it's slightly easier, but I want you to start thinking out of the box, and that's what makes you a better practitioner. You get more information with less distress for the baby. So back to this baby, we're going to do this examination all the way up through here, work out what's going on, see if we need to work through the thoracics, through the lumbars, free up the pelvis, think about spinal compression, if there's anything going on through there that we need to address, which will be cranial work at the sacrum, maybe one hand on the occiput, you can, one at either, get in camera again where I am, one at either end if you can, but often you can't to start with, so it'll be one hand under the sacrum, just working with baby, seeing if you can get a feel for what's going on with the dura, thinking about the birth process, thinking about the history, working that through your head, maybe asking mum about it whilst your hand's on. So you're trying to get feedback from the tissues, trying to hone in, get a connection so that baby is like, oh, okay, yeah, this person is going to help me. Now at 11 months is going to be a little bit harder. Maybe you can't lie baby down. We've already said there's a problem, maybe doing that. So how do you do that? You sit baby on mum's lap, toys out in front. So they're sitting there with their back to mum, toys out in front. Make sure you get a pillow under baby, and then you slide your hand under the pillow and you can contact, you don't need to see my hand, you know what I'm doing. You can contact under the sacrum and get a nice hold of the sacrum there. Particularly if you push your hand into the pillow, baby won't even know you're there. You're off to the one side there. You can look away. If baby looks to you, you kind of look away, pretend you're not there. It's the game that you play. If they don't make eye contact with you, often they won't think you're there, even if they see you. It's like, oh, they're not there. Okay. Because your eye contact, your intent follows your eye contact. So you look at them, that's confronting. Maybe baby doesn't want that. Some babies do, they love it, but some babies don't. So you're off to one side, push your hand under the pillow, and then you can get contact with the sacrum, and then you can start to feel what's going on, try to do a little bit of cranial work there. Now the reason you put your pillow in there, if you push your hand down without the pillow, where's your hand? It's in mum's crotch. That is not where it wants to be. So with a pillow there, it allows you to do that. You can slide your hand up their back between baby and mum, and sometimes baby will push right back. 11 months old, they're a bit like, separation from mum. They'll push right back against mum's chest. That's fine. Again, you can slide your hand in there. Now, it's a little bit difficult. Obviously, mum's boobs are there, but you just explain what you're doing because you can't really get a pillow in there. And obviously what's happening is the back of your hand is against mum and the front of your hand is against baby. So often that's fine. You explain what's going on. You do that, and often you can bring them forward a little bit and get a little bit of gap if you can. Sometimes they're coming forward onto the bench anyway to play with the toys. And so that's not a problem, but sometimes they'll slam themselves back up against mum. You get your hand in there and you can feel what's going on with the thoracics. Then sometimes you can get your hand around the front as well, but that's a little bit confronting. It kind of, they sometimes might pull it away or whatever, and then you have to take it off again and just work on the back. Again, there you can work on the back of the occiput. Slide your hand in the back of the occiput when they're seated, which brings us nicely on, segue in very nicely on to working on the cranium. So we worked here first. Important, particularly in this case, we know there's something going on in the back, but also I think important in most babies, especially that first treatment you see them, you're creating space and slack in the system, you're getting to know them, you are working up to working on the cranium, which is going to be more difficult. Now, when you work on the cranium, you want to be working, if we take the skull, initially I would draw a line here, and I would say you want to be working from here back, whoops, wrong way, backwards, because this is not in line of sight of baby at 11 months old. Now with a younger baby, it's okay, you can come a lot further forward. But as you start to come, you could probably come here, but as you start to come over the top here, baby starts to be like, uh-oh, what's going on here? And doesn't like it. And it can be a lot more sensitive as well. So you want to be working, I would say, around that back area to start with, because after all, a lot of what we're doing here is cranial work. And so a touch through here, this is like a newborn fetal skull, so you can see the actual size here. My hand is contacting, over 50% of the cranium. And so let's say this was baby here and they were up against mum, and we'll put them to one side, you see. So you bring your hand in here and you can contact here at the back of the skull. You might not even drop your fingers on. Your fingers are just off here. And if your fingers are off, it allows your intent to be off a little bit more as well. You can pull off a little bit more and be more sensitive. And you're just getting a feel for what's going on. Can you start to feel what's going on with this cranium? Then the fingers can come down gently if you can, and you can be sensitive. The thumb, you have to be careful with the thumb. A lot of intent in the thumb, so you can end up boring in. So often you just want your thumb slightly, definitely not with the end pad on, just like kind of, let's get you in. Like here, can we get this shot into, yeah. So it's like that, so it's resting lightly. And from there you can get a lot of information. If you work with cranial rhythms, you can do that. I don't work with cranial rhythms with babies. I find it often counterproductive. Our rhythm that we want to feel, that often isn't the rhythm that baby's working on, and so you can be imposing a rhythm without even realizing. Okay, not true for the slower rhythms so much. Now, when we're talking here, we're talking about this elongated skull. So what are we talking about? We're talking about it's longer in this distance than it's wider in this distance. So effectively, what we want to think about here is we want to be widening this shape on this skull. And we want to, and so you don't worry about so much as reducing this length. We don't want to make baby's skull any shorter. But what happens is if we get the width, then the width will match the elongation. And then we're in the money. We're doing well. And if I switch to the adult skull, because I don't have disarticulated baby skull, and the point is it's so blasted small you won't see anyway. But what we want to do is get this lovely arch going through here. And so if I pull off the mandible and we look at this underneath here, then if we think about this, we want this to be slightly wider. Now obviously we don't want to break it apart like that, but if we think about a high narrow palate, what's happening is it's narrowing down. It's narrowing down in this field, so it's shorter across here, and we want to widen that. Now, yes, you can come on and work, like if it was an adult, you could work on the mandible and the maxilla and the zygomas and all those sort of things. But in a baby, I've already said it's a little bit difficult to work through here. So you can work indirectly on the maxilla and areas like that. But if we come back to our baby's skull, really, we're so young here. I know it's 11 months old in this. They're not a newborn, 11 months. But it's so young here and so undeveloped through here, that if we get the forces through here working nicely to free up through the fascia all the way up through the hyoid, all the way up through here, preventing a pull through here, and we've had the lip tie release as well, which is helpful, and then we start thinking about all the forces from above pulling through here, then that is going to be our target. So we're going to work from the back with cranial techniques to try and open that up. We're going to think about the shape. Often I'll try and get my hands on like this, and without being too close to the front. No, I'm having trouble getting the camera in today. What's going on? I've got the mirror on, so it's mirroring it, so when I go left, it goes right. I tell you what, this is harder than treating. Getting it wobbly in the right place. So yeah, you can probably come back to about, come on, Jonathan, get your act together. Yeah, here we go. And let's angle that like that. So you can probably come to say here, and baby is probably going to be all right. That maybe this comes back a little bit, so you can access that area. And often what I like to do is and I'll put my hands down, I'll often like to just exaggerate that. I'll exaggerate that shape. I'm thinking about the way the ventricles move, and I'm kind of just, and my hands will often come off like a bellows, and I'm just trying to draw. So they're not contacting, they're coming off, and they're drawing up, dropping down again, drawing up, dropping down there. So there's an exaggeration of what's going on through there. Now there's just one technique, and you have to make sure that's appropriate, etc., etc. But it's something that I haven't seen other people use as often, so it's one of the things that I offer to you there as a suggestion. And often what you can do with that is you can often be off the skull. And so you can try to, in this kind of extension thing, when we think about this baby's closed down this way, narrowed this way, and we want to create more width, then you can often try to get that width. Just open that up, particularly if they've had vaccinations, anything like that. Often it's good to work in this area and really open this, allow the bellows to close. Open, allow the bellows to close. Now sometimes what you find is that one is closed, opens, and the other one doesn't as much. And you can use them still as a pair, but you might be just then thinking, okay, what's going on with that one? And you then start adding your structure and your shape. You're thinking, okay, well, is that because there's a little bit of tightness down the neck on that one side, and that baby was in this C-shaped pattern? Was it maybe because of the birth trauma, something happened like that? And so you're trying to get a biggest picture, a closer picture as you can. You're driving me nuts today. As you can, why this one is holding, the other one isn't. And you feed that into your hands, and then as you do that, often you'll find it starts to release a little bit, it starts to open up into that area. And so we're trying to encourage that extension, that lack of extension. We're trying to get a little bit what we describe as more flexion. The paired bones are opening more. That's what we're looking for. Now, also, when we think about that, we don't want to force that, because this baby is presenting, and like Mum says they're hitting all their milestones, the digestion is good. So it's this shape of the skull and the high palate that's worrying the dentist and now the mum. So we want to improve that, but also baby is presenting with a lot of health, a lot of vitality. So we'll be very careful to not mess that up and, trying to override that. And look, if we're being gentle, we can't really. All we can actually do is really upset baby, and baby thinks we're a bit of a waste of time because we're trying to force the pace. So using techniques like that, you don't force, you're just suggesting, opening. Yeah, you're just suggesting this opening. How would this how would you feel about this? Oh, you don't like that? Okay, why don't you feel that you like that? Is there something going on with the tissues? And you get a feel for, maybe down that left side, whatever. And then you start to work with that. So you're working down that chain, trying to get to what was at the bottom so that you can work on cause and not work on symptom. Now, to come back to this, what would also get us in the game a lot more is we start thinking about the dura, and we start thinking about the reciprocal tension membrane. And I'll just cut to a little shot here where we're walking through this RTM, and we can see here through this 3D anatomy here, which is amazing, is that you can see how the influence of the dura all the way through this whole cranium. Now, not only this where we picked out the different parts of it, but you've also got the dura enveloping the whole of these cranial bones. So the cranial bones kind of float in this dura. And so it's not just that sickle and the other areas we saw there, but it's also all the way around this. So you cannot influence the dura without influencing the bones. You cannot influence the bones without influencing the dura. And so if we're talking about shape, then we need to consider what's happening with the dura and the reciprocal tension membrane, which of course then connects us all the way down the spinal cord to the sacrum, and thinking about what's going on through there. So there's a lot to consider here, but that's good. We don't want to let it overwhelm us. And it's like, not that I'm any good at golf, I gave up many years ago, but sometimes when someone's learning golf or a golf professional tries to get someone to adjust their swing actually gets a lot worse, because it's like, do this, do that, and there's so many different things to think about. And so we think about all these different aspects. It can be, oh my God, how much is going on? But when we talk about them now in a tutorial setting, what happens is when you go back in, your key is to get your nervous system calm, to get your intent in the right place, not to be too like, we're going to fix this baby. You know, obviously you care, but not to be really overwork that, and to be in a lovely place where you're going to radiate out a healing vibe, to put it like that, and also be calm under the face of fire. What does it mean under the face of fire? That might be a lot of questions from mum and dad, or it might be your own ego going, oh, I really want to do well with this one. Or it might be baby being upset. You're going to be like nice and steady Eddie all the way through that. And that gives you that lovely base in order to start working with the other things that we talked about. And so you might remember some of this tutorial and think, oh, what about if I did this? Or what about if I did do that? So you could watch this again before you treated that baby, but you don't have to remember it all. And you don't have to like refer to your notes, because that gets you too much up in your head, and baby feels that. Your hands go cold then. You're too much up here. You want to be in your hands. You want to be in this nice space. And then with that contact, that nice, lovely contact, then you can start to explore. What about midline? What about the cranial rhythms? What about the shape of this? What about baby's nervous system? What about autonomics? What about birth trauma? What about the fact that the parents really had trouble conceiving and they had a couple of miscarriages before? Emotional things. So all of this starts to come into play, and you're with your hand there kind of going, what about? What about? What about? You're asking a question, but you're not asking a question in an aggressive way. You're providing an opening for baby to tell them more about you. You're exploring. And if you do that, what will happen is this information that you've already watched this video, this information will already be there for you, and you'll be able to call on it, and it will come into your hands and your head when you need it. And you'll think about, oh, I remember Jonathan who talked about, that palate coming down and that extension cranium and that connecting back to the RTM and all the way down to the sacrum. And so that's interesting. So when I work at the sacrum here, I can feel that there's a restriction. It's not working as well as I like it to be. It can feel like heavy in my hand and a bit stuck and not enough life. And so I can ask that question. I wonder how this, or if this is connected to their cranium and their extension face and their high palate. And you'll get often an answer in the tissues. There might be like a direct, yes, I am. Oh my God. Yeah, I'm glad someone's talking to me. Bodies don't talk to me like that. They do talk to some practitioners like that. So you're lucky if that happens to you. You might get a softening, or just a little bit of an intuition of a way of where to go next. And you might get something called arcing. Arcing is when you put your hand on the body, you wait, feels good, starts to respond, and then you just get this intuition to put your hand somewhere else. You're arcing to another place. You put your hand there, and then you might keep your other hand where it was, or then you might get, oh no, I need to bring this on. So you might have one hand on the sacrum, and then you get a arcing intuition to put your hand behind the thoracics, underneath the thoracics. Adult or baby, doesn't matter. Wait. Okay, yeah, a bit more sacrum. They're working together. This is starting to work, that's nicely. And then you might get a sense of, oh, it's disappeared. I don't feel anything. Then you've got to wait a bit longer, because that might be because it's finished, in which case waiting a bit longer doesn't matter. Or it might be as it's going through a still point or a process where it's gone beyond your threshold of being able to palpate that. Actually, I correct that. Your hands still feel it, it's just you haven't been able to register it in your head yet. Yeah. It's a little bit like someone with syringomyelia or a nerve problem that has no feeling. Doesn't mean they're not being burned. It's physically still happening to them, but they just don't register it in the brain. This is still happening. The healing is still happening. You just haven't picked up on it yet. So you just wait a little bit. Whoops, get those hands a bit. You wait a little bit. oh, now it's come back a bit. Okay, that's interesting. Let it go again. Or, no. Okay, well, now I'll take my hand off. Or you get that thing, okay, I get a feel to bring my other hand around. It's weird because it's mirrored. I'm expecting my other hand to move. You bring the other hand round and now you're AP on the chest wall, anterior and posterior on the chest wall, and you work through that. Yeah, so lots of things to explore there. How long have we gone? We're at half an hour, so I've gone a little bit into just in depth and explore. It's really my job here to open doors for you guys. It's your job to walk through those doors and explore the room and to see where it takes you. So good luck with that, with this practitioner, with this baby, but all of you working with babies, the babies really need you and you need them, because when we're exploring this work, it really makes you dig deeper, and that is something that's going to change you. It certainly has changed me. You know, over the years, if I hadn't worked with patients in general, particularly babies, then I certainly wouldn't be the person I am today. And I certainly don't mean I'm perfect, but I'm a lot more towards perfection than I was, 10 years ago, 5 years ago, and certainly 20 years ago. If you met me 20 years ago, you'd be like, what? This guy's going to be an osteopath? No way. Absolutely no way. When I used to go drinking with my mates, they used to call me the Tatty Devil, which was an old Walt Disney cartoon where they go, and you can probably see a little bit of that in me anyway when I talk, because I get quite animated. So you imagine me with 3 or 4 pints in front of me. I never got aggressive or when I'm whacking everyone, but I got so excited. It was a little bit embarrassing really, but there we go. So, what happens is, I still keep that kind of charge in me. I don't want to lose that. That's part of me. But working with babies, working with adults has allowed me to change and adapt and become a more balanced person. So hopefully that is your journey. You already are on that journey, and we're more balanced than me to start with. So think about where that will take you.